So, maybe it's worthwhile thinking about where we start. None of you are scientists, so I'm trying to make this a little bit lively. At Stony Brook, we've had this really interesting relationship between different investigators and the responders themselves, trying to figure out what's going on for these people. Mental health is such a huge component of that. You know, most of our responders have some symptoms. Even if they're not clinical symptoms, there's a little bit of symptoms, right? And that sort of pervades throughout, and we're going to build on Robert's talk about comorbidity here a little bit. But I'm going to sort of go backwards and tell you a little bit about my family. So I was raised in a very loving household, but my grandfather was, of course, at the war, and he had chronic PTSD. So, you know, as a kid, we were always told not to wake him up because he'd come out and he'd punch you, which was sort of always a funny thing, to see someone as both a risk and a source of love. I think what has happened at Stony Brook is that there's been this relationship in a similar sort of way, not that similar, I guess, but there has been this sort of relationship between Evelyn and Ben, who would normally give this talk, but he's currently in London because he just had a grandchild. Where they sort of talk about the role of mental health, and we talk about how it gets embodied and how this sort of circularity between mental health and physical health occurs and what it means, right? And so what has come out of it is that we try to understand why people are reporting having mental health problems, what it means for them, how they internalize it, and then, of course, what does it actually do, right, if anything. So you can sort of see this with, you know, sort of maybe not a preliminary, but like one way that this plays out is through the cough, right? So, you know, PTSD is in itself a memory kind of disease, right? It contains flashbacks, it contains nightmares, which are memories of the event that are stressful. And then it contains emotional responses and behavioral responses and difficulties, right? So, well, what can you think about with the coughing? Well, the coughing is, on the one hand, physical, right? You actually cough. There's a thing. We can see it. We can watch it happen. On the other hand, it's also mental. It's a reminder that you were somewhere that you had to cough. And so the cough brings around this sort of reminder of the event. And then the reminder of the event, of course, can cause some coughing. The thing with mental health is that these comorbidities are often kind of like this. They're non-specific, right? And they kind of get into the medical realm a little bit. So they can cause a misdiagnosis, but they can also cause, we think, real disease, okay? So in this discussion at Stony Brook, we have basically taken the view that the mental health is really, A, it's real, we know that, but B, that there's really, people are reporting about something that's going wrong for them, right? And therefore, we should take their word and try and figure out exactly what's going wrong for them. Now, one of the things that I think is interesting and was certainly gotten us involved in this is that people with mental health problems, they take longer in the clinic, so they're more expensive. We have to talk to them more, so that's nice. We get to sort of experience that. But they're also more complex patients. So like the cough, they have these physical symptoms, and you have to figure out, like, what is this? Is this part of the mental health problem? Is this something different? Is it something new? What's going on? And these things can be chronic, right? Mental health problems are chronic. There are many people with chronic mental health problems in our clinics, and so we're trying to figure this out both on the short term, but also, you know, like what's happening for you today, but also on the long term. What's going to happen for you, to you, or with you for the next 20 years, right? So we started with, in our research, that something must be going wrong with these patients. They're reporting a lot of different symptoms. Something has to be happening. So that has led us to a couple of different types of research. Ben is heavily involved in epigenetic research. The idea here is that the mental health is causing some sort of genetic modification as to how your genes are actually regulated and used and expressed in everyday life, right? So there's transcripting that's changing, there's the ways that it's being expressed itself, all right? So we're focusing on trying to understand that. And we've got, I think, a paper coming out soon on that. The next component of what we're trying to do is understand the sort of memory aspects. So about 35 to 40% of our responders at Stony Brook report having bad memory, and that it's getting worse. So we started looking into neurological conditions. The interesting thing with neurological conditions is that they can cause a bunch of nonspecific symptoms, right? So PTSD being located in the brain, it's not a long distance to the brain itself, and then the brain, if it's dysregulated, can cause all kinds of stuff to happen, often at low levels, right? So we started doing cognitive research to figure out, are people who are reporting memory problems, are they actually experiencing memory problems? What do those look like? Are they associated with the mental health? Are they associated with exposure? That kind of thing. The other thing we noticed was that a lot of people, as part of course, mental health, are also reporting being tired a lot. Fatigue is a terribly non-specific symptom, right? You get tired for a lot of different reasons. You might be on treatment, you might be, sorry, I'm supposed to look for a yellow light, but I realized that actually noise. My red light's on, all right. I didn't know where to look. All right, there you go, okay. So we think that there might be non-specific changes to physical functioning as well, right? So if you're getting tired, maybe you're also just not walking that fast. Maybe you're not getting up that fast. Now the funny thing with this cohort, right, is that people are starting to get older. And the funny thing with age is that, as we all get older, we rack up comorbidities, and the mental health component is an important part of that comorbidity. And so what we're trying to do now is understand how are things changing for people as they get older, how are these comorbidities interacting, and is there something underlying all of that, or is it sort of just what's expected? Anyway, so I guess the point here that we're most interested in, and I think it'll be reverberated throughout, is this sort of interaction back and forth between the mental health and the physical system. All right. So